My name is Fatima Munoz, and I'm a researcher that I'm representing the U.S.-Mexico Board of Health Commission. But I would like to mention that I just recently finished my postdoctoral fellow here at UCSD, the Division of Global Public Health. And for some, I think now for 5 years, with my mentors, Dr. Richard Garfield, Dr. Mari Zuniga, that is here with Dr. Stephanie's strategy group, we actually start working with Mexico, specifically in Tijuana, and focus on HIV and the co-infection with tuberculosis. That, as you know, it's a very important area in this region because it's a challenge. So many things and many factors that we have to consider, and definitely we have to work together because this affects both sides of the border. So we started this work. There is a latent tuberculosis infection among persons with HIV in Tijuana, Baja California, and we call this project COVID. So I will refer this project, this specific study as a COVID. Could you hear me better, I think? Okay. That means Cuidado VIH integrado con tuberculosis. So it's integrating HIV and TB services care. Because maybe you know that in Tijuana, as part of the Secretary of Health, we have only 2 clinics, and that one is the Capacit, and the other one is General Hospital. So to change. And for now, the services that we are providing in Tijuana are in different clinics. So one is specifically for HIV and the other for tuberculosis. So a little bit about the backgrounds, of course, all did you know. So the tuberculosis is actually, it's a problem worldwide. So not only in one region, and as the problem maybe in Tijuana is very different than Mozambique, but it is in the region that we have. So it's an infection disease that affects 1/3 of the world population, and also is a leading preventable cause of death among persons living with HIV in the low and middle income countries. Specifically here, it's Mexico. And in the HIV perspective, it's increase the risk of infection, reactivation, and progression to the active disease by Mycobacterium tuberculosis infection specifically. And it's well known that a person with HIV will have increased risk to a person that is HIV negative to the transmission and also to get the TB infection. And specifically, 2 of the strategies that it is in Mexico and also in other parts of the world, it's the reducing the mortality, include the early initiation of antiretroviral therapy, and also the preventive therapy with isoniazid. This is 6 months in Mexico. This is something that we want to introduce and implement more routinely. So in Mexico, we have approximately 180,000 persons living with HIV, and 60% of the deaths are associated with tuberculosis. Specifically in Baja California, has the highest incidence rate. So I think it's not the picture here. It's the format. It's the picture, so it's not showing. Yeah. No. Yeah, it's okay. So I think it's fine. I just wanted to show a picture with the country, just that it's highlighting the Baja California, who is in the top of the list, and for showing that it's the highest incidence rate for tuberculosis in the country, with 55 cases per 100,000 population, and also the highest mortality rate with 50 per million population. And obviously, it's not compared with what is happening in the other parts of the world, but it's really very important. We are in the top of this list. In Mexico specifically, little has been studied of latent tuberculosis infection in people with HIV. And despite the coordinator work that we had been doing with locally and also on the state and federal level with both programs, HIV and tuberculosis, that have increased the coverage of HIV testing among patients with tuberculosis in care. But there are still barriers and challenges to improve the prevention among people with HIV, and implement the routine testing for tuberculosis in the HIV clinic. So this is the main purpose of this study, just to show how important it is to implement or integrate the services to tuberculosis prevention in clinics with HIV care. So this study provides the first estimates of Mycobacterium tuberculosis infection among people with HIV in Tijuana, Baja California, and also demonstrates the availability and routine TB testing in HIV clinics. So that was the main goal of this study. This study, it was funded by CENCIDA, that is the National Center for Control and Prevention of HIV in Mexico, and also through the Secretary of Health. So we conducted this study in the two clinics, specifically at Capacites and the other in the SAI, or General Hospital HIV clinic. It was a cross-sectional study that was conducted in Tijuana from December 2015, and we finished the data collection of the test in 2016 in May this year, actually. So the study population with patients with a recent diagnosis with HIV that received medical care at Capacites and General Hospital, so older than 18 years old, and the recent HIV diagnosis is less than 6 months, and with CD4 cell count for more than equals 100 cells. Or if it's in the chart or in the medical record, if there is no result for the CD4 cell count, so then they were eligible to participate, but as soon as they complete the test and we have the results, so we will determine if it's lower than 100, so they were not eligible to participate. And also no history of active tuberculosis, and provide a signed and informed consent. Again, so the pictures. So in the way that we work for this study, so we work very close with the directors of the clinics, the HIV clinics. So the patients, they were selected according to the eligible criteria, and then the directors or the personnel for the clinics, they provided the list with the potential participants. And that it's very important to mention that it was not easy in the process, that apparently the list of the patients that were eligible to participate, it was hard to actually find the patients. So we have a lot of work during the process with the directors and also with the programs. And the data collection, so we also administered the questionnaire, and we use the quantiferon for the test, and clinical records also to get more information. And also this study was approved by the IRB committee from the U.S.-Mexico Border Health Commission. So to determine the Mycobacterium tuberculosis infection was determined using the interferon gamma release assays. Specifically, we used the quantiferon, TB golden tube, and also the other covariables that we included as part of the surveys that we administered. There was sociodemographic, some risk factors, clinical variables related with the HIV diagnosis, and also to know how many patients will receive the antiretroviral therapy, and that another related variable related with the intentions for the patients had to initiate the therapy. As part of the analysis, so we use the descriptive statistics and frequency to determine the proportion of the patients with positive or negative quantiferon, and the bivariate analysis to compare the characteristics of participants with a positive quantiferon test versus the negative test. And also, we included the multivariate model that was developed by manually entering factors with significant univariate associations at the first level, the bivariate level, the 0.10, and those who were considered correlated with the Mycobacterium tuberculosis infection, they were considered to the final model, and only variables significant at the p-value, the 0.05, were included. So I would like to explain a little bit. So the first list, we had 180 patients that were eligible to participate for this study. But then during the process, we tried to contact and find all the patients, and we only found actually 99 because the phone number it was not correct, because the patient it was not adherent and they just did not show up in the visit. So it was a very interesting process because it's very common that patients that even if they are receiving the treatment in the clinics, they actually is not consistent the visit. So this is a problem that we have, and actually they have in the clinics, that this is why the adherence is low. And when they try to find a patient, not always it's easy because they don't have the correct address or the correct contact information. So this is one of the main barriers. So we enrolled 99 patients, and only 3 refused to participate because some of the reasons that they mentioned, they didn't understand really about to participate in the project, and also they were a little scared about to know another infection. So it was enough to know that they just got the result for the HIV positive, and they didn't want to know that also there's a potential that there is to get a positive test for the tuberculosis infection. And at the end, the data of only 85 participants, because they met the eligibility criteria, were considered for the analysis. So as part of the participants, of the 99, 72% were recruited at Kappa seats and 28% at Psy or General Hospital. So a little bit about the characteristics of the population. So they referred to the 77% they refer to be male, and 22% female, and just 1 transgender. And the average of the age was 31 years old, and almost all they referred to they were born in Mexico. And about the level of education, so they have less than a high school of education, so it's a little bit less than the half. And 65% they refer to be single, separated, or divorced. And this is another very important factor for us, because this is one of the main barriers that has the patients. They have to go to the clinic and every month. So it's about the monthly income. So as you can see, that half of the participants, they referred that the monthly income is 3,000 pesos a month. That is the equivalent of maybe a little bit more of $150 per month. So it's very, very low. Some of the results of the clinical variables. So 53 of the patients, they referred to start the antiretroviral therapy. So just to highlight that we have the less than 6 months that patients were registered in the clinic and start the process to make the diagnosis and all the protocol for different. And here you can see that only 6 patients were found with less than 100 cell counts, or CD4 cell counts, and the other were eligible to participate. This is the 85 patients. And for the the viral load, it's 37%. They showed them more than 50,000. Again, it's all the images is gone. This is the most important graphic. Please. What happened?
Is it on your own computer? Is it on your own computer?
Yeah.
Let's see. Let's see if we can find it.
Could you see here? I don't think so. Okay, so maybe I can ask, what do you think was the result of the prevalence of latent tuberculosis infection among the population that were participated? So we only got 3 indeterminate, and this is what the low CD4 count that I showed, only in 6 patients, but the prevalence was at 32%. Because we actually performed the test and the assay for the 99 participants that were invited to participate. So the overall, we got the result of the quantiferon. Even if according with the eligibility criteria, only the data of 85 participants, 85 patients were included in the final model. But the overall, we found that 32% of the prevalence using quantiferon to determine the latent tuberculosis infection, and 34% only with the patients that were eligible according with the study. So this number were actually very important to demonstrate that it's needed actually to integrate the treatment now in the HIV clinics. The one is to, in the time the patient actually is the first visit to get the diagnosis, and the other test for a patient with HIV positive new patient, also to do in the same time the test to determine the infection of Mycobacterium tuberculosis, and also if it's necessary to follow the protocol and to determine if it's active or not, and to start that treatment for latent tuberculosis infection for the prophylaxis. So this is actually the results of this. So among the patients that were positive, we asked about the intentions to start the treatment. And you can see here that 100% of the patients, they said that, yeah, it is important, so I'm willing to take the treatment and also the medication, because I consider it's important for the condition. But you can see that to come every day during 6 months or more for your medication, only 80%. That is still high, but not all the patients were willing to go every day to the clinic. And now I think it's important to mention that the DOT, it's required and it's mandatory for patients with TB, active TB. But now in the guidelines in Mexico for patients with HIV, it's also required, or it's also mandatory to do the DOT for latent tuberculosis infection treatment. So, but at this point, it's actually, it's not a routine that patients with positive tests is taking the medication. So this is something that we would like to implement or integrate the services as part of the HIV clinics and services. And also, if you had to take the medication every day for 6 months, how likely are you to complete your treatment? 96% they said that yes, so they are very likely to complete the treatment. In the bivariate analysis, here you can see that some of the variables, the demographic, were not significant between the patients who result with a positive or negative test, and only had children's where 55% of the patients with a positive test were more likely to have children than the other group. And another important variable here found that it's a place they live. So patients who report they live in the albergues or rehab center or shelter, they were more likely to present a positive test. And also the employment, it was another variable important that were related with the 68% of the patients that referred that they have a full-time or part-time employment. That means that can have the more income or more secure income, they were more likely to result with a negative test. And regarding the use of drugs and alcohol, the patients who referred or they report to use methamphetamines in the last 6 months, or marijuana, or just the drug use before or during sexual relations, they were more likely to result with a positive test for quantiferon. And here about the alcohol consumption, it was the opposite. So the patients who report that they consumed in the last 6 months the alcohol, they were more likely to present a negative test. That it was interesting, these results. So related with the clinical variables, there was no significant difference between these two groups. And I will go to the final the final model. So in the final model, the multivariate analysis showed the factors that were independently associated and positive associated with latent tuberculosis infection were to patients who report the CD4 cell count of more than 500 cell count, and the use of employment. So it's the patients who had a full-time or part-time employment, and the factor independently associated, the word negative also associated with the, positive associated with the infection, it was the use of drugs, the methamphetamines, and negative associated the CD4 cell count and the employment status, So overall, the results of the study revealed that patients with HIV, they had a positive results of latent tuberculosis infection, where 32% have more vulnerable characteristics that for tuberculosis, and that have been related and demonstrate the social issues that is important, like employment, the use of drugs. Also, it is a context that we have to consider, and also the income or the employment. And it's interesting that we found that 17% of the participants, even if they were just recently diagnosed with HIV and also with tuberculosis, they were actually active drug users. So they still are using drugs. And also, even if most of the patients were able to take the medication for tuberculosis, if they result with a positive, with the infection, we found during the process that there is not enough knowledge and understand the complexity to have the HIV and also with tuberculosis, and how vulnerable they can be, and how important is to the adherence for the treatment. So, and I think that one of the strengths or the most important outcomes of this process is that as part of the results, and that is demonstrated the necessity to integrate the services of tuberculosis into the clinics and HIV, and we submitted the second phase for this project, and since CEDA approved to continue and continue this activities or to continue doing the tests as part of the routine of HIV, the patients that are receiving services for HIV in these two clinics, and also the coordination and the work that we actually work in collaboration and very close with the two HIV clinics, with the staff, with the personnel, with the state level. We have the support completely to do the activities here in Tijuana and also at the federal level. So the next step is not only to do the tests, it's also to monitor the treatment during the 6 months and offer the prophylaxis and monitor the prophylaxis for these patients. And so this is the collaborators, and thank you very much. And I'm so sorry that I didn't show you the graphic, the most important graphic, and also the picture.
Thank you, Fatima. Sometimes it happens with ITs, but we will have time. Perhaps you can show during the break tea to those who are interested. We are late on our schedule, but also there has been a mistake on the assignment of the time. If I don't follow this, it seems that I'm not doing a good job, but there is a mistake there in the time. Okay, we can take one person only. Thank you. No one.
Okay. Good.
Okay.
Thank you very much. Okay, Dr. Munoz, thank you for your presentation. The work is very important. I'm glad that it will continue. My question is whether you have any sense for, in the population that you worked with, what may be their binational mobility, if any? Or do you have a sense for whether these are residents of Tijuana that don't cross, or
Binational movement?
are these patients, some of these individuals, do they cross the border, or in the study population, did you have any information about their mobility?
Yeah, actually, we included this question that we asked the patients, and it was not frequent. It was not one factor that they mentioned or reported. The cross the border, it was one of the majority of the population. It was, I don't remember exactly the percentage, but it was very low and not significant for the final results for this population.